22 years. That's how long I've stood at the operating table. And in those 22 years, I've seen something that nobody in medicine likes to say out loud. Some of the most damaged patients I've ever treated weren't damaged by their disease. They were damaged by their surgery. I'm Dr. Shoaib, cardiothoracic surgeon, and today I'm going to tell you what most surgeons won't. Not because surgery is bad. Surgery has saved millions of lives, including lives I personally fought to protect. But because the body you're walking around in at 65, 70, 75 is playing by completely different rules than it was at 45. And the medical system is painfully slow at catching up to that reality. So let's talk about it honestly. First, here's what changes inside your body the moment anesthesia hits. General anesthesia isn't like falling asleep. It's a controlled chemical shutdown of your entire nervous system. Your lungs become passive. Your heart gets stressed. Your kidneys slow their filtering. And your brain, this is the part nobody warns you about, your brain gets confused in ways that can last for weeks. There's a real medical term for it: post-operative cognitive dysfunction. In patients over 70, it shows up far more often than surgical consent forms ever mention. Some patients describe coming out of major surgery feeling like themselves. Others describe waking up as a stranger in their own mind. Foggy, slow, not quite there. That fog sometimes lifts in days, sometimes in months. Sometimes it doesn't fully lift at all. Now add this: roughly 40% of adults over 75 meet the clinical definition of frail. Not old, not slow, clinically frail, meaning their body's internal reserve has dropped below the threshold needed to absorb major physical trauma. By age 85, that number climbs towards 60%. Frailty isn't a character flaw. It's a measurable physiological reality. And it changes everything about how a body responds to being cut open. The real question, the one worth asking before any major operation, isn't can you survive the surgery, it's can you survive the recovery. Those are two very different questions. Operation 1. Open heart surgery in the wrong patient. Coronary artery bypass surgery has genuinely saved lives. I won't pretend otherwise. The concept is straightforward. Blocked arteries are bypassed. Blood flows again. Heart works better. For a healthy 62-year-old, this can be transformative. For a 79-year-old managing kidney disease, early cognitive decline, and diabetes, the math changes completely. Here's the detail that shocks most people. During open heart surgery, your actual heart is stopped. A machine takes over, doing the work your heart and lungs normally do. For a body with strong reserves, that's manageable. For a frail elderly body, that bypass machine puts every organ under simultaneous assault. The research shows that in frail elderly patients, major cardiac surgery carries a 30 to 40% risk of serious complications: stroke, kidney failure, extended ventilator dependence, prolonged mental confusion, and in the highest risk patients, up to 15% don't survive the first 30 days. Not 30 years. 30 days. What most patients are never told is that an alternative frequently exists. It's called TAVI, transcatheter aortic valve implantation, a catheter-based cardiac procedure. No chest cracked open. No heart stopped. Far gentler on a body that needs gentleness. Not a 6-hour battle. Not every patient qualifies for it, but many do. So before signing any cardiac surgery consent, ask one direct question: am I a candidate for a catheter-based approach instead? That single question has genuinely changed outcomes for people. Ask it. Operation 2. Aggressive spinal surgery that fixes nothing. Back pain after 60 is almost universal. I have never met an elderly patient who didn't mention their spine at some point. And the surgical response to that pain: spinal fusions, multi-level decompressions, metal hardware inserted along the vertebral column, is being recommended more aggressively than the evidence supports. Let me be direct. Some spinal surgery is genuinely urgent: active spinal cord compression, loss of bladder or bowel control, progressing weakness in the limbs. These situations require intervention. Immediately, no debate. But elective spinal fusion for chronic back pain in older adults, the data is uncomfortable. Research published in a major spine journal found that in patients over 65, complex spinal fusion carried a complication rate exceeding 40%. Blood clots, wound infections, hardware failure, and a particularly cruel long-term consequence called adjacent segment disease, where the vertebrae above and below the fused section begin breaking down because the spine's natural movement has been permanently removed. You fix one section, The sections next to it pay the price. For years, and the outcome that matters most, pain relief, often shows no meaningful advantage over non-surgical management. Physical therapy, targeted nerve injections, and structured movement programs frequently deliver comparable results in elderly patients without a single incision. I had a colleague, an exceptional spine surgeon, who once told me, "Shoaib, sometimes the best surgery is the one nobody performs." I've quoted that for 15 years. If someone has told you spinal surgery is your only option for chronic back pain, write that in the comments. Because you deserve a second opinion, and you deserve someone who explains why surgery beats everything else for your specific situation, with data to back it up. Operation 3. Major cancer surgery when the cure becomes the cause. This one demands care. Because the word cancer does something primal to the human mind. It says remove it. Now, whatever it takes, and I understand that impulse completely. But 2 decades in surgery has taught me that the goal of treatment isn't only to eliminate the tumor. The goal is to give a person more good life, more quality years, more mornings that feel worth having. Those two goals don't always lead to the same decision. The Whipple procedure, surgery for pancreatic cancer, involves removing major portions of the digestive system. It takes up to 10 hours. In a younger, healthy patient with no serious underlying illness, it can extend life significantly. In an 80-year-old with cardiac disease and reduced kidney function, the surgery may technically succeed, tumor removed, procedure completed, and the patient still dies within weeks. Not from the cancer, from what the surgery did to a body that had no reserves left to spend. This is called futile surgery. It happens more than anyone in medicine wants to acknowledge. A landmark American College of Surgeons study found that nearly 1 in 5 elderly cancer patients undergoing major resection experience what they called failure to rescue. A complication arose that the weakened body simply couldn't survive. The question worth asking your oncologist directly is this: if we don't operate, what does my realistic picture look like, with radiation, targeted therapy, or watchful monitoring, given my age and current health? Many patients never ask that. Many are never offered the chance. Sometimes the answer behind that question is genuinely better than the surgery being recommended. Operation 4. Joint replacement, when the timing is wrong. Hip and knee replacements, done well, on the right patient, at the right time, are some of the most successful operations in the history of medicine. I say that without hesitation. I have watched people walk into my clinic, barely managing a shuffle, and walk out, months later, moving freely for the first time in years. The transformation is real, but elective means you choose when. And that timing matters enormously. In patients over 75 carrying 3 or more serious health conditions, heart disease, type 2 diabetes, chronic kidney disease, obesity, joint replacement carries meaningfully elevated risk. The most dangerous complication isn't the operation itself, it's what can happen afterward. Deep vein thrombosis, blood clots forming in the legs during recovery, can break loose and travel to the lungs. In younger patients with strong circulation, this risk is manageable. In elderly patients with sluggish blood flow and reduced cardiac output, it is substantially more dangerous. Add to that post-surgical pneumonia from reduced movement, hospital-acquired infections, the physiological shock of prolonged anesthesia on a system already running at reduced capacity. None of this means don't have the replacement. It means, is your body currently in the best possible state to receive it? Controlling blood pressure, stabilizing blood sugar, building physical strength before surgery. The concept has a name, prehabilitation, and evidence shows it can dramatically reduce complication rates in high-risk elderly patients. Some hospitals now require it before they'll even schedule these operations. Ask your surgeon about it. Most patients have never heard the word. They absolutely should. Operation 5. Emergency abdominal surgery, and why you need to prepare before the crisis. This one is different. You don't schedule emergency surgery. You don't research it calmly. It arrives at midnight on a Tuesday, and it doesn't ask permission. A perforated bowel, a ruptured appendix, severe internal bleeding. These are situations where the only option is the operating table. But here's why it belongs in this conversation. Understanding the risk in advance changes how families make decisions in those impossible moments, and it changes what you do before the emergency ever arrives. Emergency abdominal surgery in patients over 75 carries mortality rates between 30 and 50% in the most severe presentations. Not from poor surgical technique, not from inadequate care, From the simple devastating reality that an elderly body under sudden massive trauma is fighting on every front simultaneously. The liver, kidneys, lungs, and heart are all impacted at once, and the inflammatory response that a younger body contains within days can escalate in an older body into systemic inflammatory response syndrome, a cascade of organ involvement that is as serious as it sounds. Two things you can actually do with this information. First, don't wait on symptoms. Persistent abdominal pain, unexplained bloating, significant changes in bowel habits in anyone over 60 deserve prompt medical evaluation. Catching problems early almost always means treating them before they become life or death emergencies. That single habit changes everything. Second, and this one matters deeply, have the conversation with your family now. Not in the hospital, not at midnight in a corridor with someone handing you a form. Now, what would you want if emergency surgery became the only option? What quality of life matters to you? What would you refuse? These aren't morbid conversations. They are some of the most loving and protective conversations a family can have. Before any significant operation, every patient over 60 has the right to these answers. Write them down. Question 1. What happens if I don't have this surgery? A surgeon who gives you an honest answer will tell you if nothing urgently changes in the next 6 to 12 months. That means you have time. Use it. Question 2. Is there a less invasive alternative? Robotic surgery, endoscopic procedures, catheter-based interventions. Options that simply didn't exist 15 years ago are now available at most major hospitals. Ask specifically. Don't assume the first recommendation is the only one. Question 3. What does recovery realistically look like for my specific situation? Not the average patient, not the brochure. You, your heart function, your kidney numbers, your current medications, your living circumstances. If the answer is generic, push for specificity. Question 4. The one most people never ask. What is your personal complication rate for this procedure in patients over 70? Surgeons track these numbers. They know their outcomes. A confident ethical surgeon will answer that question directly. If the response makes them visibly uncomfortable, that discomfort is itself worth noting. I want to tell you about a patient. His name for privacy is Gerald, 71 years old, retired engineer, one of the sharpest patients I've ever sat with. He came to me after 3 separate surgeons had each independently recommended open heart surgery. 3 opinions, same answer every time. Gerald wasn't afraid of the surgery itself. He was afraid of losing himself. 2 years earlier, he'd watched his wife go through a major operation. She came through it, technically successfully, but something shifted in her that never fully came back. She was slower, confused at unexpected moments, not quite the woman he'd spent 40 years with. He looked at me and said, "She went in as my wife. She came out as someone I had to take care of." I've carried that sentence with me ever since. When I reviewed Gerald's complete profile, frailty score, kidney function, cognitive baseline, medication burden, I gave him 40 minutes instead of 15, and I told him what the data actually showed for someone with his specific numbers. Surgery was an option, but so was an aggressive medication protocol combined with structured cardiac rehabilitation. And for his particular profile, 5-year outcomes between the 2 approaches were genuinely comparable. He chose the non-surgical path. That was 4 years ago. Last month he sent me a photograph, standing at the summit of a hiking trail in Colorado. 2 granddaughters beside him, both taller than him now, all 3 of them grinning like they'd gotten away with something. A surgical recommendation is not a verdict. It is the opening line of a conversation. You are not a passive recipient of decisions made about your body by people with more credentials than you. You are an active participant in your own care. You have the right to every hard question, every alternative option. Every day you need to think clearly. The surgeon holds the scalpel. You hold the choice. And that choice, made with full information, honest conversation, and clear eyes, is the most powerful instrument in medicine. More powerful than anything I have ever held in an operating room. 5 surgeries. Real risks, real alternatives. Open heart surgery in frail patients, where catheter-based options now frequently exist. Aggressive spinal fusion, where the evidence for pain relief is far thinner than most patients are told. Major cancer resections, where the goal must always be more good life, not just a removed tumor. Elective joint replacement in severely ill patients, where preparation and timing matter as much as the procedure. Emergency abdominal surgery, where your best protection is catching problems early and talking to your family before the crisis arrives. None of this means avoid surgery. Surgery saves lives. I have seen it. I have been part of it. It means be informed. Ask the hard questions. Request the alternatives. Get a second opinion, and if needed, a third. Your age is not a vulnerability. Your questions are not an inconvenience. What question would you most want answered before a major operation? Tell me in the comments. I read every one. And if this gave you or someone you love a clearer picture of how to approach a surgical decision, share it. That share might matter more than you know. Everything shared here is general medical information drawn from published research and clinical experience. Every person's situation is individual. Before any surgical or treatment decision, please have a full, direct, unhurried conversation with your own physician. They know your history. They know your body. And that conversation, honest, specific, and complete, is exactly where good medicine begins.